Hey everyone, welcome to the Relay. I'm Val Emmons, your host, and today on the Relay, we're diving into something that happens every day in healthcare, but it rarely gets the attention it deserves, the small moments that can make or break a patient's journey. And I'm joined by Benjamin Cantor, principal investigator at the Microtransitions in Care Lab. He's also a PhD student at Boston University's Center for Psychiatric Rehabilitation. So, Ben, you're studying what we know as microtransitions
Yeah.
for your PhD. Is that what?
My PhD is on kind of transitions in care more broadly. Micro transitions in care is a rather new concept.
I'm really
Y-
excited to hear that your transitions of care is your study because for years we have literally pushed transitions of care and no one knew what we were talking about. And now all of a sudden everyone is talking about it, and I think that's fantastic.
Yeah, so my PhD is going to be in rehabilitation sciences. I have my doctorate in occupational therapy already. So I was, first trained as a clinician, and now I'm back in school to get further research training in transitions in care focused research and nursing home research, because I have kind of found this passion for these micro transitions as an occupational therapist who you know was I've spent probably 10 years in nursing homes in a variety of different roles. When I was a kid and teenager, I was volunteering. I've been in a rehabilitation aid role, recreation aid role, and then obviously in the role of, occupational therapy provider. So over the years, I've noticed first in the recreation volunteer roles and then as an occupational therapist that trips and outings outside of the facility are really important to nursing home residents. The ability to kind of leave the building and experience, the world just like anybody else. And enabling those trips is really important to people's well-being. And that was made really clear, I think, during COVID-19 when people couldn't go anywhere and everybody was stuck in the facility and couldn't have any visitors taking them places. And so that was when my colleague, Dr. Green, and I decided that we wanted to explore these micro transition outings more. The term micro transitions came from the Post Acute and Long Term Care Medical Association, previously AMDA, now PulpMed, out of the Transitions of Care subcommittee that Dr. Abel Marie Green and I both sat on at the time. And we kind of realized that these trips out of the facilities, they're a change in location and there's a change in custodial care responsibility from the facility to whoever is escorting the resident on the outing, just like other transitions focused on it.
That's the thing that I wanted to ask because most people just think of that as a transition. Why the micro transition?
So when we think of general transitions of care, we typically know them hospital to ER, ER to home, you know, home to nursing home to any of those locations. We're really talking about what I think of are as like these big events in a person's life where they're moving usually for a clinical change in clinical status. So for instance, when you go from home to the hospital, your clinical condition has acutely declined and you're going to the hospital and then you get better and you get discharged, right? Or alternatively, you don't get better or don't get better enough and then you move to a nursing home. And, if you decline again, you go back to the hospital. If you get better enough, you go back to the community. So we see a change in clinical status that's associated with most transitions of care as we have come to understand them, which are big for anybody, whether, you're 25 or 95, going to the hospital, moving to an institutional setting, moving back from an institutional setting to a place in the community, independent living. These are big deal trips for anybody, regardless of your age. But micro transitions can be just going to CVS or going to McDonald's. And oftentimes, if you are an able bodied young individual, those are really easy to navigate, especially if you're cognitively intact. And so I guess the micro has to do with the fact that it's a transition of care because there's that change in location and change in custodial status. The person responsible for your care is changing temporarily, but it's not changing for a longer term situation like it would when you go to the hospital or you go to a nursing home for like, days at a time. And it's not changing because of it changing clinical status. You're just going to CVS, you're going to a restaurant, you're going to the bank, and the risks are the same, but we often don't think of them as a big deal. And so we came up with the term microtransition to identify that while it may seem smaller, it is still at its core a transition.
So when we speak in terms of transition, I don't know if you were familiar that we had a summit in DC last September, and we talked about, well, the reason for the name of the show is the relays, because we feel like a transition to care is a handoff,
Yeah.
kind of like a relay race. So in that aspect of it, so in a micro transition, who would we be handing off the patient to?
Well, it depends on the microtransition. So we think of microtransitions as falling into three categories. The first category is you have outpatient medical appointments. The second category is recreation or non-medical outings. So CVS, McDonald's, bank, nail salon, wherever. And then the third category is room changes. So depending on the type of outing, that will change the handoff. So for instance, to a non-medical outing, first you're going from the clinician, right? Maybe the nursing staff in the facility. There's a handoff then to the escort, usually a van driver, a facility van driver, maybe a Medicaid transport, or maybe it's to a lay caregiver who, like a family member who's taking them on the trip to the outing, to the outpatient provider. Then there's another handoff, right? So if that escort isn't going into the clinic visit with them, you have a handoff from that escort to the provider. Then after the trip, there's another handoff back to the escort. Then there's a third handoff back to the facility. So you have multiple handoffs in rapid succession in order to complete this loop. Unlike a regular transition of care that we think of as an inter-facility transition to the hospital, which we really think of as one way, and then they're there for, however long, and then there's a second transition back. This is kind of a full round trip where there's multiple handoffs in rapid succession. We see the same thing with escorts without the provider, right? There's an escort going to CVS with this person, and then they come back. So, when they get back, they're getting back maybe within an hour or two, and now there's another handoff. And we need to think what happened on that trip to CVS that, the nursing home needs to be aware of. Imagine you go to CVS and someone has a headache, or you go to McDonald's and there's a CVS next door and say, I have a headache. Okay, well, why don't you take some Advil, Mrs. Smith? I have some in my purse. And then they get back to the facility and the facility asks them how the trip to McDonald's and CVS went. And they say, oh, it went well, but I have a headache now. And they say, oh, let's get you some Advil for that. Maybe the patient has a cognitive impairment and they don't remember. And now they're taking another Advil. Maybe they go out to McDonald's every day and they keep getting these headaches and they keep double dosing on that Advil, right? So they're receiving more medication than they should be receiving. With the outpatient trips, we see, orders may be missed, so maybe the facility said, oh, you're going to the cardiologist to see what happens on that trip. As a result of this trip to the cardiologist, see what they want to do about your Lasix. And they're waiting to hear from the cardiologist. They send the packet of all the medications that person is on. The cardiologist never opens that folder. They don't even realize that the patient was on XYZ medications if maybe, it's a substitute cardiologist filling in for the day, and it's not their usual provider. Or perhaps the nursing home has made a recent change and the cardiologist medication list is outdated. Alternatively, maybe the cardiologist makes a change and puts it in the My chart. My chart for nursing home patients is kind of like this abyss, where it kind of goes into the ether, because who's reading the My chart? The resident with, cognitive impairment probably isn't reading the My chart. Maybe the caregiver doesn't have access to the patient's My chart. And the nursing staff don't have access to the patient's my chart, but maybe the cardiologist is assuming it's entering that my chart and that the patient or their caregiver is reading it. And so the nursing home never receives that order to change the dosage of that Lasix or whatever medication it is. So there's lots of little handoffs, and things can go wrong on either side of that handoff, especially with a medical outing. Yeah, so we depending on the type of trip, we see a different handoff taking place and different ramifications and adverse events that can occur. Room changes are interesting because they happen within the same facility, but sometimes we can still have a handoff that of non-medical information that is critical and has clinical consequences. So you might think, oh, this patient, really likes it when you remind them every morning to go to the bathroom because they often forget, and then they have incontinence and they can't really remember on their own. Maybe that's not something that's written in the chart per se that they need to be reminded, but perhaps it's kind of just a known entity to those who work on that unit or that wing. And so if they move to a different floor or they move to memory care, maybe it's not known that that patient needs that component of reminding them to go to the bathroom. And so um, things that might not officially be in the chart may get lost. So those are some examples for each of the three types. I mean, I know I just covered a lot of ground because we're really talking about multiple types of transitions when we talk about micro transitions, which is more of a broad category. But I hope those examples were helpful.
Right. No, very helpful, and just not just for me, but for listeners who might not have heard this at all. Because, like I said, transitions of care is relatively a new concept over the last 15, 20 years. But definitely micro transitions is a new one. And so, why do these things keep happening during these trips to the ER and then back? And is it because there's no log kept, or like what are the biggest things that you see that aren't being communicated clearly, and why aren't they being communicated?
Well, with you know big transitions, sometimes there's also a lag in communication around ER visits. The patient gets sent to the ER, and the facility may not even be aware that the patient ever left the facility in the first place. It's a day or two before the clinician may even be aware that the patient was sent to the ER from a micro transition. The facility, if it's happening at night, the facility may not find out until even the next day. I think the reason for that is that often it's not clear for escorts who to call, if there's an emergency on a trip.
That seems like you would have that before you left with the patient. You know what I mean? Like if I were to get in an accident, who do I call? Right.
I think a lot of people are trained to call 911, and they say, okay, I call 911, the patient is headed to the ER, I've done my job. If you were to, just as a totally random example, right? If you were to see somebody at, I don't know, I went to Disneyland recently. If you were to see somebody at Disneyland who was choking, you would call 911 and maybe stay with them until 911 showed up. You would, I think, assume that the paramedics had the situation under control and took them to the hospital and things kind of work out. I think we see similar things on micro transitions, that when an escort is with somebody, that they assume that the facility is going to find out. The doctor at the hospital is going to call them. The hospital and the physician assume that the facility has already been notified. A common theme with micro transitions and transitions of care in general, I think, is that everything is somebody else's job because they're
Right.
such
And
small
yeah.
trips that don't have a lot of clear medical consequences. And so we see that when there is a clinical consequence occurring, it happens because nobody who on the clinical team felt into their purview. So, even something as simple as a trip to, McDonald's, whose job is it to make sure that the swallowing orders are followed on that trip? The speech therapist may say, oh, well, I don't really deal with the clinical trips, and trips out of the facility. I just do the rehab. The medical team may say, well, that's a speech therapy issue. The recreation team, because it's a recreation trip, may say, well, that's a clinical issue with swallowing orders, and I don't do that. So everybody kind of has a reason for it not being their job. When there's not clear procedures and it's not clear who has what role in the process, there's no standardized operating procedures, we run into this situation where things don't get done because nobody in a facility has been assigned to do a certain part of the microtransitions process.
So do you think that's because we have lack of staffing right now? Because this seems like if we know these things are happening and they matter and they make a big difference, what's the disconnect? Why are these things allowed to happen? Why not communicate and coordinate them better?
I think that awareness is the biggest component. I think that it is very typical for us to think of these trips to CVS, to McDonald's, to the park, to the mall, to the cardiologist as routine occurrences in a facility. I don't think we necessarily think of them as having massive clinical consequences in terms of the logistical components of getting the patient there and getting the patient back and what goes on the trip itself. Other than maybe, please let us know what happened on your, nephrology visit, your neurology visit, and let us know the orders. I think that these other components of notification and making sure orders and things are followed on the visit, such as swallowing and dietary orders, and those components are overlooked because from the perspective of a cognitively intact individual, which are usually the people providing the care, are cognitively intact, I would say that those individuals are not experiencing many challenges with this problem in their own life. And so sometimes historically it's been overlooked, unlike a hospitalization where it's very clearly a problem regardless of who you are.
So, what is a simple change that providers could make that would improve these micro transitions? And, what can patients or families do to protect themselves? And then also, what are the tools and scripts that are used to train folks? Like, you don't just hand these people off to any person that needs a job. There has to be some sort of training that would prevent this.
Yeah, so we published a a paper recently outlining a new tool that was just published in JAMDA that nursing homes can use, called the MASS tool, the Microtransitions Adverse Event Sign In Sign Out form. Typically, when people leave a facility, they sign time in, time out, what's the name of the resident, what's today's date, and maybe where are we going. And what we did was we added to that tool a list of things, um, like skin tear. Was there an ER visit? Were there orders if you went to the clinic? What provider did you go to? Um, so a bunch of questions about what occurred on the outing. And upon returning to the facility, we have the escort and resident complete this form, which basically says, did anything crazy happen on the outing? So that way, the nursing staff can know. So almost like a warm handoff tool
Right.
that is then filled out at reception and then sent to the nursing staff so that they have the up-to-date status as to if anything occurred on the microtransition that they need to address that could have a clinical impact. Like a skin tear, which if untreated could lead to an infection, but if treated early, uh, is easy to address before it ends up resulting in what we would consider to be a macro transition or like a hospitalization or one of those larger, more clinically urgent trips. So it's all about communication, as is most transitions of care information. And you can also provide a checklist ahead of time. So, orders that the patient has around swallowing and dietary needs, orders around medical status and functional status. The patient needs a wheelchair, they have a catheter, be aware of all of these things before they leave. So, a checklist before and a checklist when you get back that's given to the nursing staff are two really good techniques to help mitigate the risk of microtransitions. Still enabling the trips themselves, I think, is important.
No, that's very important, as we learned during COVID. Also, a lot of these folks during COVID didn't even have interaction with people. They just sat in their room, and so I think we have to have those trips. I understand the quality of life about having these outings and getting out, because a lot of these folks don't get to do anything but sit in their room. But beyond that, how do these micro transitions fit into the larger conversation around transitions of care? So, I mean, what I mean by that is like, are we missing the foundation by focusing too much on the big system fixes instead of these smaller interactions?
I think that the answer is yes and no. Transitions of care of all kinds need continued work to improve. That's why there's a National Transitions of Care coalition trying to work on those things. So, you know, but I do think that these smaller trips have just kind of smaller but impactful trips have been somewhat neglected and not really conceptualized as transitions of care. I also think that the same problems that exist on these larger trips exist for these smaller and less clinically acute outings. I don't necessarily think that solving those problems for micro transitions will solve the problems for larger outings or larger, macro transitions, that is. But I do think that it is a piece to the puzzle that has not yet been fully explored. There's lots and lots of literature out there and research on, how going to the emergency room and coming back, there are all of these different barriers to proper communication taking place. There is less literature, notably less, on smaller outings and room changes and how those things may have similar risks. But in our early work in our microtransitions in care lab, we have found that about 50% of the orders may be not reaching the facility from outpatient appointments because we haven't been paying attention to that.
So, okay, so I have a question. So, I've been thinking about this. So, I know like the larger transitions of care, which I don't want to focus too much on that because that's not what we're talking about today. But in comparison, they cost a lot of money sometimes to hospitals for readmissions and things of that nature. So these smaller micro transitions, do they tend to cost the facility money? Because sometimes that's the motivator in correcting these things, or is it just the patient that suffers?
Yes. So I would say that everybody can suffer. So I'll give you a really basic example. Let's say that I am a patient with Parkinson's disease, and I am going to go to my neurologist in order to hopefully be diagnosed with that Parkinson's disease. Maybe I'm not sure what movement disorder I have yet, and the nurse practitioner in my facility isn't sure what to diagnose me with. So I'm going to be sent to the neurologist. Okay. And I get to that neurology appointment, and the neurologist does their exam and diagnoses me with Parkinson's disease. They prescribe a medication for Parkinson's disease, for movement disorders. And that medication is supposed to be administered, say, once daily once I return to the facility. They make the order and they send me back to the facility from whence I came. Now, we're in this situation where we get back to the facility and the physician or medical provider at the facility says, "So how was your trip?" And the patient says, "It went well." And they ask you how it went, and you say, "I don't really know." Maybe that patient has cognitive impairment and they're not sure. Maybe a Medicare escort attended the trip with them but didn't go into the appointment with them. And so they're waiting on the orders from the neurologist to come back to the nursing home. Those orders never come. So now the patient has spent their time and risked an adverse event leaving the facility. Staff at the facility spent time sending them there, maybe with the facility van and having a facility van driver take them. So the facility has spent time and money taking them and putting the patient's safety at a small but notable risk. The provider has spent 25, 30 minutes of their time seeing the patient and giving them a diagnosis and filling out an order. That order went into the My Chart that never reached the facility. And so at the patient, facility, and outpatient provider level, there was wasted time and money. So that's just an example how when the orders don't make it back to the facility, you really are throwing away money in a way. You might as well not have attended the trip if nothing's going to come of that outpatient appointment.
So wouldn't the simple task be for the facility to follow up with the other facility?
Sure, it's it's not always clear it's not always clear where the appointment took place. If the family member scheduled the appointment, you may be in a situation where that appointment, the staff weren't even aware that it took place. Maybe they just came and took them to the appointment and never notified the nursing staff. So there's some education for families about the importance of notifying the facility staff. You also have maybe a situation where the provider is assuming that the nursing home knows about the appointment and is going to call the front desk to get those orders. You may have a situation where the outpatient provider isn't aware that the appointment took place from a nursing home resident, and they may think that that person is in the community, so they have to ask, and they may not be asking if that person is in a nursing home. And nursing homes are understaffed. Like you said, they don't necessarily have the time capability to call every single specialist that a resident may see. There's lots of reasons why we may not end up with that order back in the facility. That order also then has to be charted by the nursing staff. And so there may be some documentation challenges in getting those orders to be entered into the chart, right? I might even return with an after visit summary and give it to the nurse from my, say, cardiology appointment, but then the nurse has to take that after visit summary and scan it into the chart. So there are multiple handoffs taking place here in rapid succession, leaving the facility to the escort to the outpatient provider back to the escort, and then the escort to the facility staff to then chart. So you've got like 5 or 6 handoffs there happening within the span of like 2 or 3 hours. So it's easy for things to get lost.
So have you tried to apply the 7 essential elements for just regular transitions of care that we have? Have you applied that to these micro transitions of care in studies?
So we actually developed a microtransitions in care framework that incorporates some of those aspects into them in the various. There's a mnemonic that we like to use for microtransitions that is somewhat more specific to the type of trip. So we use the mnemonic CAPES for that. The first is the C, which is communication, as you may have expected. And the second is the A, which is adverse event mitigation and planning. The P is for purpose and destination of the outing, which is, a cost benefit analysis of whether this outing should take place given the patient's acuity and risk for adverse events and things like that. And then the destination. So are you going to the beach? Are you going to the mall? What is it? Open area. And then we have the environment and equipment considerations for E. And then S is the skill level of the escort. And so we use this mnemonic. It was developed through a Delphi study of 39 interdisciplinary transitions of care and nursing home experts, but those are incorporated in. So obviously the multidisciplinary collaboration and information transfer are incorporated into that. The follow-up care and the provider accountability is a part of that kind of communication piece. In the family patient engagement, you can kind of see that in the skill level of the escort. Whoever is going on that outing with the patient needs to be involved and their skill level needs to be taken into account. So we use this separate mnemonic of CAPES because it really gets at more of the skill level of the escort, because there's this escorting component that isn't necessarily the case when we just look at a hospital to skilled nursing facility or a hospital to home transition where somebody may be going in an ambulance or something. So there's this other lay person component to the transition process itself because there are so many handoffs. So we thought about using an existing transitions of care framework, but we couldn't find one that fit really well to the unique considerations of microtransitions. Those principles are indeed incorporated back into the CAPES framework best practice recommendations, which are published in JAMDA.
So does this concept lead to a different action or just kind of a different way of talking and discussing transitions of care?
Both. I think that words matter. And when we hear, in my clinical experience as an occupational therapist who's worked in nursing homes for many years in a variety of roles, you hear people say things like, oh, she's just going to the dentist. She's just going to the cardiologist. They're just going to CVS on a CVS field trip and they'll be back soon. As if that just means, oh, it's not really something that we as the nursing team or clinical team need to pay too much attention to. Their mom is just taking them out for the day. As opposed to thinking of it as, oh, they're going on a micro transition. This is a transition in care. It's a micro transition in care. That makes it sound like, oh, we as the clinical team, they're going on a micro transition. We better make sure that we're checking in about that transition, right? So at this point, while there's still lots of work to do around major transitions in care, there is still, an awareness that when you have a transition of care, that falls under the purview of the clinical team. And so by changing the way we talk about these outings and room changes to go from just, oh, they're just undergoing a room change or they're just going to CVS to they're undergoing a transition of care, we change the perceived scope of whose responsibility it is to be involved. And we can build on the work that the National Transitions of Care Coalition and other organizations like AGS and PulpMed have already done to say this is a transition of care. Therefore, we know this is a multidisciplinary effort. This is something we need to engage the patient in. So just by classifying it differently, that then leads to the understanding that action needs to be taken around it.
Right. Well, is there anything you would like to leave listeners with that we didn't cover?
I would say check out the best practice recommendations and check out the mass sign in sign out tool, and you can see if it's something that you might be interested in for your facility. The Microtransitions in Care Lab is always putting out resources around microtransitions that can assist clinicians and administration in making sure that these trips are safe and accessible. There are now resources out there to assist in tracking and improving these trips, and take a stab at it. And I'll also just make sure people know that they can reach out to me at my email, which I'll also give you if they have questions about microtransitions or implementing those resources. And my team and I are always happy to help with that.
Okay. Well, we want to thank you today. And I just want to close with, let's make this real. Like every time a nursing home resident leaves for an outing, a visit, or an appointment, they're stepping into a transitions of care. That's a real thing. And too often, nobody's really owning those in between moments at all. And so
Sure.
what
Yeah.
was said and what was understood, what actually got followed through on, as you alluded to, but that's where it seems like those things fall apart. And whether you like it or not, the problem is real. And until we fix those small moments, we're going to keep seeing these same outcomes. And so I want to thank you, Benjamin Cantor, for this enlightening conversation. And I want to encourage you to keep on with the transitions of care, because one of these days it's going to sink in what we've been working on all these years.
Sure. Thank you so much for having me.
You're welcome. And you're welcome to come back anytime.
All right, then.